pop up. We're recording this for later use. Julian, maybe you can pop up the slide deck, and we can clean up the participant screen here to get people promoted here who are going to be speaking. Got this slide deck happening there, Julian. You get a minute. All right, go ahead. We'll go quickly through some faculty news and accolades. First, promotions and appointments. A few promotions to professor. Want to congratulate Dr. Zackerson from the section of trauma and critical care surgery. Was promoted to professor. She's been with us for 3 years now, starting as an associate professor, and really rapid ascension to professor with major impact, not only internally in our department, but nationally and internationally in areas around equity, advocacy, and activism for support of the underserved. Really good work coming, and congratulations, Dr. Zackerson. Next, Dr. Oda in cardiac surgery, really an extraordinary surgeon who's been with us since 2013 and has been promoted through the ranks and now up to professor over the summer. And really quite an expert in the surgical treatment of aortic disease, and an all-around great heart surgeon. Works in some of the most complex areas, including heart failure and the VAD program in transplantation. Is very highly productive researcher as well. Congratulations, Dr. Oda. Next slide. Some new hires and some additional, well, to the promotions first. A few promotions noted below. Dr. Scourin Orlategui was promoted to assistant professor. Dr. Koitkin in general surgery promoted to associate professor. Dr. Chakshi in pediatrics promoted to associate professor. Dr. Sarah Ferris in urology promoted to associate professor, and Dr. Chelsea Dorsey promoted to associate professor. And you saw the announcement earlier in the week that Dr. Dorsey has now been also been promoted in our department to vice chair for equity, diversity, equity, and inclusion, and as we all know, is having a major impact on our, not only our department, but on the medical center, and really in part of the evolving national conversations on this critical issue. New faculty that have come on board. I'll just say, we'll say a little bit about them. Oh, here we go. Got them. Great. Thanks, Julian. In cardiac surgery, we welcome Dr. Chris Salerno as professor of surgery and director of the adult cardiac surgery program. He'll be surgical director of the heart transplant program as well. He comes to us from a really busy practice in Indiana at St. Vincent's, where he had about as academic a practice as anybody in the most traditional academic medical center. Extraordinary clinical researcher, highly published, started and led the transplant program there with extraordinary results. Does great clinical research in devices, and we really couldn't be more pleased to have him come on board. Next, also in cardiac surgery, we have Dr. Nishida has joined us as a clinical associate in cardiac surgery, particularly in the area of ECMO, cardiac support, LVADs, and procurements. Welcome, Dr. Nishida. Next. In general surgery, Dr. Sarah Schubeck joined us. She is a breast surgical oncologist who trained at Michigan and completed her fellowship at Memorial Sloan Kettering. She is an outstanding young health services researcher who is jumping out of the starting gates here incredibly rapidly in her areas of interest around value and quality in surgical care. So welcome, Dr. Schubeck. As you know, we are building an amazing general surgery group out at Ingalls, which has now added Dr. Paul Signorino. We heard his comments earlier on one of the cases, joining Dr. Deshmukh and Dr. Pardawala out at Ingalls, joined us from DuPage. And as you can see, we are so thrilled that our Ingalls team is diving right in and participating in all the activities of the department as well, and really bringing a lot of wisdom and experience from the community-based practice into the academic practice. So we're thrilled to have you on board. Next, I think was that and Dr. Biederman, our own Dr. Maureen Biederman, Biederman, who is our microsurgery trained plastic reconstructive surgeon, who we consider part of our old family. She was a Pritzker grad. She did her plastic surgery residency here, did a McLean Ethics Fellowship, and finished the microsurgery fellowship program at NYU, which is certainly one of the premier programs. And we were thrilled to be able to recruit her back to the department, a familiar face, and she is already hitting the ground running, already very, very busy in reconstruction and gender affirmation surgery and other highly complex and important areas. So welcome back, Dr. Biederman. Next, and also in plastic and reconstructive surgery, Greg Lamaris, who is joining us from Texas, from UT Houston. He is a hand surgeon and microsurgeon, extraordinarily busy and talented surgeon who we were lucky enough to recruit from Texas, who joined us a few weeks ago, hitting the ground running. Really brings a lot of talent and experience to reconstructive capabilities in upper and lower extremities. So welcome, Dr. Lamaris. Next, our own Drew Benjamin has returned after trauma fellowship at Penn to join trauma critical care surgery. As everybody knows, he was our general surgery resident here and obtained a master's in informatics while he was here. So we're very excited to have and welcome Drew back to the family. Next, and Omar Rahim has joined us as an assistant professor in urology from Tulane. He is a specialist in men's health, male infertility, and reconstruction, and has been very productive during his time at Tulane. We were lucky to lure him up to Chicago, where he's also hitting the ground running in men's health, and very busy, very charming, very energetic, and we're just delighted to have him here. And I think that was it. Was that the last one? Yes, that was it. Okay, for the sake of time, we're just going to buzz through the accolades quickly. We saw Takiota's promotion to professor. I want you to pay attention to the information that's coming out about our heart transplant program, which we don't have too much time to boast about here, but is clearly the #1 in the country. And I think there's going to be a lot of communication going out about that, the #1 in quality and outcomes. In colorectal surgery, Dr. Olategui finished her master's degree in public health sciences. Konstantin Umansky completed his term as program director for ASCARS, and Dr. Shogun got a small business grant for characterization of the effect on extracellular matrix-based adhesion barrier on the healing of bowel anastomosis. Next slide. In general surgery, Dr. Ng got a Comprehensive Cancer Center award. And Dr. Koikin, we heard about his promotion to associate professor. Congratulations. In OHS, Dr. Blair was featured at an international meeting in July. Next. Plastic surgery or pediatric surgery, Dr. Slidell was senior author on a Lancet publication on injury severity scoring. Deb Leff was appointed for a 2-year term as surgical liaison to their bioethics group. of the AAP, and she's on the executive committee of the surgical section of the AAP. That's a big deal. And preview, she just got promoted to associate professor as well, but it didn't make the deadline for the announcement, so we get to talk about it again at the next meeting. Dr. Henry was selected as the AWS Kim F grade visiting professor at University of Minnesota. Next slide. In plastic surgery, a couple of top docs. We all know they're all top docs, but Dr. Zachary and Dr. Bauer were noted recently. Next, in transplant, we'll send this around and everybody can read the incredible patient letter that we get, and we get fairly routinely from our transplant group. We'll hear about that. We heard about Dr. Zacharson's promotion to professor, and Dr. Prakash was named Teacher of the Year by Swedish Medical Center for our trauma teaching of the Swedish hospital residents. A number of top docs in urology. Again, they're all top docs, and many of them were also named in Chicago Magazine. And we heard about Dr. Rahim's appointment here. He's got a new award as well from the AUA. Next slide. In vascular surgery, congratulations again to Dr. Dorsey on her promotion to vice chair. And she is also was elected to serve on the executive committee of the Bowman Society of the medical school. Dr. Skelly, Dr. Milner named by Chicago Magazine as top docs. And Dr. Milner was elected secretary of the Midwestern Vascular Surgical Society, which I think is a pathway to president if he does a good job. Next. And I think that is it. Okay, let me turn it over to Dr. Alverdi and to Janine Grohar to give us an update on research.
I think the best thing for everyone here is that we do have a statistician for the Department of Surgery. We're really excited. Rachel started last month. I sent out an email last Friday with regards to steps with reaching her, and so there's her email. I can resend the email I sent Friday. I'm also uploading it to the intranet. Please reach out to me if any questions or comments, especially if you've been working with Ted Karrason in the public health department. Because I think one or two faculty are working with them, and we can talk about that. Next slide. We're really excited about our grant portfolio. As you can see, we have brought in about $6 million. You can do the next. And our awards, we've got 5 or 6 R01s, R44s, P50, and a KO8 for Dr. Shogun. I'm really excited that Danielle has 2 new pre and post award coordinators, Katerina Makowiak and Ariel Medoff. And they've been helping Danielle kind of organize and allowing faculty to have box accounts for their new grants. And so we're really excited about that. I feel that that's very helpful for Danielle because she's been extremely busy. Next point, actually next 2 points. Next one. Yeah, John, can you speak about that?
Sure. We're starting the basic science visiting professor program, anticipating 2 or 3 visiting professors. We're going to start from within the institution outside the Department of Surgery, and we will be sending out announcements on that shortly. And also we're going to have our monthly lunches for PIs involved in basic science research, which will allow people to go to the Quad Club, present any data that they wish for the group to look at and discuss. Thank you.
And then quickly, we have actually built the office to what I hoped it would be built by October 19th, which is my 2-year anniversary. We have 7 research coordinators who are supporting 26 protocols, and we've got about 20 protocols in the pipeline. I'm really excited that we hired a budget and contract manager who will be negotiating our industry-sponsored clinical trials. She started a few weeks ago. We're going to give her about another few weeks for training, but we're really excited about that. We're partnering with the Department of Medicine, so I'm happy to know that we've got someone there to help us. And then lastly, we hired a regulatory coordinator to replace Shirley, who retired. And yes, so we're done hiring for a moment. And then next slide. Keep going. One more. And then our ranking went from 29 to 24, as you can see.
Yeah, those rankings are funny because of the way things are tallied, and departments go up and down. We are on a pretty sharp upswing, and we're in an area where we, based on our trends, are likely to skip over a number of departments in the 2021 ranking. So we're excited to see how that comes. We're really doing well thanks to this group and the dedication and productivity of the faculty. Questions for John and Janine? Can put them in the chat if there are any. We're getting, I know that issues around URA have been a problem. We have had some really good meetings with them about clinical trials contracts. And I think we're finally getting some of those issues, which are outside of the department and even outside of the BSD solved and improved. Any questions or concerns, any comments anybody wants to make? You can raise your hand and get promoted again if you need to, if you want to. Okay, why don't we go on? I forgot what's next. Volume. Go ahead, Doug, you're up.
Thank you. Quickly, we'll take a review of the case volumes. I know that I've heard from quite a few of our chiefs that the targets actually seem to be quite high this year. And if you take a look at where we are based on the September data, we clearly haven't hit the budget targets for the year, but I'd also ask that you take a look at what the projections or the budget targets are for the rest of the year. It's quite a bit flatter than we've historically budgeted in previous years. And we are starting to see, a little bit of improvement in certain areas, but overall, I'd like to point out that we're still about 4% over last year and still not quite at the current budget targets. They've been negatively impacted by a lot of transfer issues, bed availability, and a variety of other operational concerns, including staffing and issues that are basically outside of the department's control for the most part. So we've had a bit of a softer start this year. We're hopeful that some of these operational issues are going to get cleared up and we'll start to see some improvement over the next year. Julian, next slide, please. This is, again, just sort of a broken down by section. I think you can see that again, the 4% above last year, but yet just about 5% shy from our current budget targets. Again, negatively impacted by the fact that we had a bit of a softer last quarter last year. We were expecting to have a stronger starting point, and we run into a lot of operational issues. And I think on-site and off-site ambulatory volumes is really key to our rebound, which is a good cue to go to the next slide. I think we're doing quite a good job in that. As you can see from here that, ambulatory total visit volume is up about 12.5% from prior year. And last year we were doing actually quite well. If you take a look at the trending from 20 to 22, you can see that there's been quite a big impact in fiscal 22. That's at least in part due to the integration of our surgeons at the Ingalls facility. So we have new volume that's being counted here and some new recruits. Our department has continued to expand. And particularly in the offsite area, it's a 83% improvement at volume offsite. Additional details can be provided to you if you're interested by location, but it's across all locations. And I would suggest that I think about 800 of that, or 800 or possibly 900 is directly affiliated with the Ingalls practice integration. Next slide, please. And here's where it's broken down, and you can see the community surgery group. It's actually 986 of those of that incremental volume, and the rest of it's really being split across the department in a way that would be aligned with our strategic direction and our focus. So I'd say overall, ambulatory volumes are picking up. We're seeing improvement there, which ultimately leads to surgery. And I think as we start to see some of the case volume, or we start to see some of the operational concerns managed on the hospital side, we should see some uptick and a reclaiming of some of that budget deficit over the next quarter. Jeff, any comments on that? That's the last slide.
No, we've had conversations across the hospital and the BSD, the dean level, and others, and there's great understanding for some of the operational issues that we're facing, and an appreciation that there are, when we see variances like this, we always dig in to try to understand them. That's our responsibility, and we try to figure out strategies to mitigate them. Some of them are clearly pandemic related, where certain types of screenings and surgical procedures in immunosuppressed patients and other situations, particularly in pediatrics where the kids haven't been back in school, have definitely impacted numbers. So we know that, the institution recognizes that, and we just manage through this. Fortunately, most of the cases that are missing here in number are low complexity, low revenue cases, so it really has less of an economic impact. The leading indicator, which is new patient visits, is up and exceeding budget, and so that's a good predictor of where we're headed. So we recognize that these operational issues are an enormous source of frustration, particularly when they result in delays in us getting bits of equipment or personnel that we need in the ambulatory space to drive the growth of our practice. We've had really good discussions with senior leadership, particularly over the last couple of days, to work through these issues. And I think we're going to get a lot more focused attention on solving them. Any comments that anybody would like to make? Yep. Yeah,
Kevin asked a question about nursing shortage, which I think it's sort of part of the operational issue, but if there are any specifics we can.
Yeah, I mean, the nursing shortage is obviously one that impacts us in a lot of different ways. Probably the single biggest area that it's impacting us is in the operating room, where this is a national shortage, as you know. This is very acute across the city, but across the nation. It's very hard to get agency nurses and replacement nurses. It's a national shortage. There are institutions in our region that have had to cut back elective surgical cases by as much as 30% because of nursing shortages. We're certainly not at that level, but we have had some incidents over the last couple of days where we've had to close more rooms due to call-offs and nursing vacancies. It's going to be difficult for the next few months in this regard until the national issue starts to change. It's obviously multifactorial. The other place it's hitting us is in the ability to get replacement staff in some of the ambulatory practices. This was the subject of some conversations yesterday, as well as the ability to be able to recruit APPs as physician extenders on some of the particularly busy services. But there's intense effort. This is Jason Keeler's number one concern. He's never felt more pressure due to this. He recognizes the issue. They're doing everything that they can to address it. We've also seen that there's shortages in some of the ancillary areas as well, perfusionists and otherwise. So it's a very challenging time with workforce shortages broadly across academic and community medical centers throughout the country. And we're not spared from that.
That's the end of the volumes discussion.
Okay, why don't we move on to the quality update?
All right, thanks, Jeff. So this is our Leapfrog hospital safety scores, and the fall score should be coming out soon. Just as a point of comparison to our local peers. But quite often when this data is presented and the email comes out from the dean and so forth, a number of faculty approach me to talk about how does this relate to US News and World Report and concerns because there tends to be a little bit of a discrepancy. Next slide. And in fact, when you look at the US News numbers and rankings that came out at the end of the summer, there was a decrease in our overall score. But I think it's pretty clear from an institutional perspective that there really is a very strong commitment to achieving honor roll by 2025. And I suspect that there will be more discussion about this both at the departmental level as well as the section level. But I just want to point out a few items that pertain to surgery quality that we can really impact this in a almost immediate fashion, if you will. Next slide. So in the interest of time, going through the methodology of the US News and World Report ranking system is too complex for this presentation this morning. But the key changes that have taken place with this most recent ranking system, next slide, is that there's more procedures and conditions that are part of the scoring system, and to that point, there's really even greater opportunity for the Department of Surgery to impact this. And as we've done with Leapfrog and other quality metrics, really take a leadership position to help our institution to achieve this goal. Next slide. And so in terms of what we can do, one of the key ways in which we can impact some of the scoring system is with regards to our surgical mortality rates. And the way that it is calculated and used in the US News and World Report is a report and a ratio of observed to expected mortality produced by Vizient, which is a third-party system. And it uses administrative data as opposed to clinical data to do the risk adjustment. And a number of areas, particularly cardiac surgery and heart and vascular in general, have really done great work with improvement in clinical documentation to really more accurately reflect the expected mortality or the denominator aspect of this scoring system. Leaders in those areas manually review and correct the comorbidity documentation in cases where there were mortalities, and templates have been created to better capture that information as well. And there's actually been individual personnel that have been hired to really help with this effort. But scaling that up, I think, is going to be a bit more of a challenge. And really, when you think about the fact that this is a ratio, being able to really identify targeted improvements with the numerator and the denominator is a really key thing, because modest changes in either of those can significantly impact the ratio itself. So next slide. So a working group looking at this O to E mortality made the recommendation that we have more visibility and way to really identify those opportunities. And so within Tableau, if you look, you'll find this a pretty useful worksheet. It's a O to E mortality opportunity finder. And the way that this graph is represented, on the y-axis is the mortality, the observed deaths, and if it exceeds that horizontal line, that's something that's worse performance. And on the x-axis is the expected mortality, which is a really a reflection of the documentation of comorbidities and so forth. So in the lower right-hand corner represents where our outcomes as far as mortality are quite good, and the robustness of the documentation of comorbidities is actually quite good. And so, there's probably, we shouldn't be spending as much effort perhaps in focusing in the procedures and diagnoses that fall into that quadrant. And when you go to Tableau, you can hover over each of these points to really identify what these dots represent. And there's filters on the left-hand column that allow you to filter by DRG or by disease system and so forth, that really allow identification of targets. And so where we can really actually make a significant impact is on that upper right-hand opportunity, where really that's about improving mortality and our clinical care. I think that being in a tertiary care system, we tend to just make the assumptions that our patients are more complex. For the procedures that fall into that quadrant, we actually document the complexity quite well, but our outcomes don't quite match that. The converse is in that lower left-hand column, where we really do very well from our observed mortality rate, but perhaps are not doing as well as far as capturing comorbidities. And so what you'll be hearing for more over the next coming months are strategies and ways, hopefully, to actually leverage things that are being done in EPIC already and avoid double documentation and so forth, to really shift the balance of these ratios going forward. Next slide. The other ways in which we can substantially impact our performance is with regards to lengths of stay and readmission. Next slide. And a key component of this is a broader implementation of enhanced recovery pathway. I did go into some detail about this at our last quarterly faculty meeting, but this clearly can impact both length of stay and readmissions. Next slide. And each section has been tasked to identify other areas for implementation, and the quality leads are compiling that, and we'll be able to share sort of what everyone is working on, so that we can really combine our expertise and share lessons learned, and hopefully make this process easier to do. Again, all the products as far as the educational materials and all have already been created, order sets have been created. It's just a matter of identifying these areas. Next slide. And if there's difficulties or questions as to what to focus on with the Tableau dashboard, you can again search by specific procedures and diagnoses and categories to really identify where there's opportunities for improvement. Next slide. But I think that there's ways of doing this that don't rely on enhanced recovery. And one of the key components of enhanced recovery is a post-discharge phone call. And certainly in a number of programs that have already implemented enhanced recovery, this has been a very valuable tool to identify patients and avoid readmission or return to the emergency room. Next slide. And so outside of the enhanced recovery patients, I think that we should really, as a group, think about ways in which we can leverage that post-discharge phone call. And I suspect that many of us already have implemented this, whether our patients are on enhanced recovery protocols or not. But these calls can really facilitate triage to either an earlier post-op clinic visit instead of the 2 or 3 weeks, which is quite common in the department, or in the near future, a more acute evaluation in the care transitions clinic, and again, avoiding the ER visits and readmissions. I think especially in the era of COVID, that additional touch point with the patient helps the patient to feel that we are engaged and involved with their success after surgery, and may help their reduce feelings of isolation. I think that it's important that our own nurse associates or APPs are the ones making these calls, since they're the ones who know the patients to begin with and have that clinical expertise to really do that troubleshooting. And in some areas, there's really opportunities to get residents and fellows involved with this process as well. As a starting point with the enhanced recovery process, there's a template for that post-discharge phone call, but obviously this can be modified in a procedure-specific and specialty-specific manner to capture the information that you need. So I'll stop there, and happy to answer any questions or comments.
Thank you, Dr. Prashant. Any comments in the chat? Any questions anybody wants to ask of Dr. Prashant? these will be probably more focused discussions within each section led by the quality chiefs. Thank you, Vivek. Let's go on to Dr. Angelos.
Thanks, Jeff, very much. It's a pleasure to give you a quick update on wellness. So I just want to start by making a quick comment that it's not just about social activities. And this quote I thought really reflected that. I'll just read it rapidly. It's from Dr. Jerkovich, many of you know, from UC Davis. It starts out as little things. Maybe the patient was not made NPO was made NPO all day for a procedure that never happened. Maybe the patient in the ED needs a follow-up appointment, but there's simply no way to make it happen. Whatever the event, the physician must tell the patient the bad news, that they cannot provide the kind of care that the patient needs and deserves, and that they are sorry. Although many efforts are aimed at helping you manage the stress of such a recurrent dilemma, the fundamental correction lies in the healthcare delivery system and not just in physician resilience. And as I said, I do think that this sort of resonated with me, and would suggest that you think a little bit about it. There have been some ongoing programs. As you know, in the last year and a half, we really emphasized supporting the residents. We've continued to help the residents manage the stress of caring for the large volume of trauma patients, largely through the peer program and some psychological counseling sessions. There are some upcoming activities, and these are certainly open to all faculty as well as residents in all the programs. I just want to highlight the Outdoors Club. This is a group planning on activities focused around an activity outside. Leah Hofer, Gus Godley, and Alyssa Varsanik from General Surgery are the residents running it. There is an outing coming up on Saturday, October 16th at 1 p.m. at an orchard. And so if you're interested, I would suggest contacting one of the residents noted here. There's also a listserv that you can sign up to be notified of their upcoming activities. In terms of a few future plans, we are hoping to increase opportunities for faculty and staff engagement as the options for in-person gatherings increase in the upcoming months. Certainly that's our hope. We are hoping to have a departmental retreat in upcoming months. And if you have ideas about programming for that, please do share them with me. I'm always interested in people's thoughts. We're planning a peer counseling program to help mitigate the second victim effect of complications, and a few additional plans. Remember that efforts to mitigate the impact of burnout relate to how we find meaning and satisfaction in our work. And the reason that I say that is that I do think we all need to remember to support our colleagues, whether they are faculty, trainees, or staff, because we all can have a major impact on the wellness of the entire department. And providing a supportive sense of community, I think, will go a long way. And so I guess I would just challenge everyone to think about how we can help each other. And certainly there's a real goal to identify areas to improve the ease with which surgical care can be provided to patients. And so really this is designed to mitigate the moral distress associated with the barriers to caring for patients. And all of the things that we talked about with respect to volumes and projections and budgets and quality, this all gets to the idea of helping us do our job for our patients. So with that, I'll stop sharing and happy to answer any questions.
Please feel free to address questions or ask questions in the chat, or raise your hand if you'd like to comment. The BSD is also just launching a recruitment for a chief wellness officer, and hopefully that indicates a deeper commitment to some of the more system-wide issues that Peter was raising here. I think that'll be important. There's a comment from Dr. Gundetti. Can we, to Dr. Prashant, can we get the template of the postoperative phone call? Yeah, we'll get that circulated. We'll do that as a follow-up. Other questions for any of the panelists or for me? Oh, there's the dot phrase is in the chat. We'll circulate that around. Maybe we could send that around in an email message as well, Vivek, so people know how to hit that. Good. Okay, everybody. Well, I want to thank you for coming to the faculty meeting. We had a really good discussion of M&Ms that highlighted systems issues as well as some of these other issues, and a good discussion such as it can be by Zoom. So thank you very much, everybody. Have a great rest of the day.